we're presenting tomorrow the ASPIRE clinical trial. It's in first to third relapse myeloma, and we're trying to build on the reference treatment of Revlimid and dexamethasone by adding a proteasome inhibitor, carfilzomib or Kyprolis. This was a very large study, 792 patients, 20 countries, and a very positive result. The study met its primary endpoint of progression-free survival with an unprecedented progression-free survival in the 3-drug cocktail arm of 26 months, a number which hasn't really been seen before in myeloma patients at relapse. It was also positive in that patients responded more frequently. The responses were deeper. Complete responses, for example, were 3 times as common in the 3-drug carfilzomib containing cocktail. Overall survival was not yet reached. Median overall survival was not yet reached in either arm of the trial. However, there is a trend in favor of the 3-drug combination even at this early stage. The side effect profile looked very good and was reassuring, because there has been some concern around carfilzomib without any randomized trial data. So that looked quite good. And then finally, and I think very importantly for patients, when we asked them how they were feeling, they reported a better overall global quality of life. The take-home message is, I think, that this study is among a number of studies that demonstrate that the 3-drug combination is always superior to the 2-drug combination, as long as the toxicity profile can be managed, which it was in this case. 3 drugs are preferable at diagnosis, and we've now shown clearly that they're preferable at relapse, and particularly when a proteasome inhibitor, Velcade or carfilzomib, is combined with an immune modulator, thalidomide or lenalidomide or Pomalyst. The results are quite dramatic, and I think the message for treating physicians is these should be your go-to cocktail of therapies, both at time of diagnosis and, as we've shown here this week, at time of first relapse. Myeloma doesn't have a monoclonal antibody for therapy today, but we're very excited about 3 monoclonal antibodies that are in late-stage clinical testing. Daratumumab, which we'll hear about next year, and at this meeting we're going to hear a lot about the anti-CD38 antibodies, daratumumab and SAR. They have slightly different binding sites on the CD38 molecule, but they both importantly have impressive activity even in patients who have failed all of their treatment. And we're beginning to see that as they're put in combination, quite very encouraging results even in newly diagnosed patients. We think that these will be very rapidly drugs that move through the clinical trial testing process and become part of our standard of combination therapies for this disease. We're optimistic that they may even convert some of our patients into a curable disease.